Thank you, Arvind sir, and let me first of all be grateful to my friends Manoj and Puri for allotting me a very passionate topic to me, making good thing even better. And I'm pretty sure that Puri could have created this title, very attractive one, and this is looking towards the future. So in the next 15 to 20 minutes, I'll be discussing about the present and also the future of automated insulin delivery devices. So before we begin our discussions, just to get an idea, because I know that I am in Mumbai and this is a place where there is a sufficient proliferation of all these advanced technologies. How many of you are aware of the earlier terminology? Before automated insulin delivery, there used to be another term which is used for describing these technologies. So, how many of you are aware of that? Can you please raise your hands? The previous terminology, you need not answer. Okay, so the previous terminology used to be artificial pancreas, and the artificial pancreas is now replaced by automated insulin delivery since the last 4 years. And this is a very interesting story. 3 years ago, I happened to be in a advisory board meeting of another specialty. Usually we are in either diabetes or related specialty, but it is an unrelated specialty. And there were physicians and surgeons in that specialty. And I was listening to the discussions, and they were also asking me my opinion on that. And then they discussed on pancreatectomy and what happens to diabetes when pancreas is removed, and how can diabetes be treated when there is a pancreatectomy subsequent to a malignancy or to chronic pancreatitis, or when the stones are removed. And then I found that I observed that there is only one physician among the audience who is aware of even continuous glucose monitoring, and the majority were not aware of even the availability of automated insulin delivery devices, and that was available already then when this ad board was going on. So the reality now in our country is more than 99% of doctors who are treating diabetes need not be a diabetologist or an endo, because diabetes is treated by doctors in all the specialties, including in the ENT or orthopedics, but they are not aware of what has actually happened to the tech space in diabetes globally. And if you have to start a technology or an automated insulin delivery, then how will you do that? And are you going to do it yourself, or are you going to refer to another specialty? And what sort of an infrastructure is required? And what is going to happen in the near future with all these new and old gadgets? And this has been the journey. And I profoundly thank Medtronic for the advancements in technologies in India. Why? Because most of these insulin pumps and delivery devices which are available in the rest of the world, they are not available in our country. And Medtronic has been there in India from the beginning, and this is in 2004 when we launched the refurbished pumps in India, and the market was growing. And now they have more than 2,000 automated insulin delivery devices thanks to the innovation, and that was AID, the Advanced Hybrid Closed Loop Systems, in the year 2022. And that has been phenomenal. And it was transformative to have the new device in India. And this is a device where the basal insulin delivery is automated once in every 5 minutes. And once it has reached maximal, and still if the glucose is high, then there will be tiny boluses which are automatically delivered. And that has been around for more than 4 years now. And for beginners who are not familiar with an automated insulin delivery, this is a simple diagram. Wireless integration of an insulin pump with a continuous glucose monitoring system through an advanced algorithm, and with the aid of a rapid acting analog insulin. So these are the 4 components of a automatic insulin delivery. And this has been the stages, and if possible, I will touch upon the stage 5 and stage 6 of innovation. This is the second generation and third generation. The advanced hybrid closed loop systems that we are discussing belong to the 4th stage of second gen automation. And this has been the original JDRF, now breakthrough T1D algorithm on the how it is evolving from the stage 1 of simple standalone insulin pumps with just suspend mechanism. And this is the overall landscape globally. And this is the available devices, but more devices are available. These are the 6 very popular devices. And remember, this is from Asia, from South Korea. And they claim that they were even before Medtronic in launching insulin pumps in the early 1980s. And in India, we have only 780G. And many people now prefer the patch insulin pumps. And there are more than 500 people in India using the Omnipod. Omnipod, though not available in our country, there are many using Omnipod. And the advancements of automation in delivery of insulin has been a reality. It has become a reality only because of continuous glucose sensors. And it's only because of the innovations and advancements in continuous glucose monitoring, this has become a reality. And for anybody who has gone for a 780G, and this is one of our own patients, this is their statement. Within a week of initiating an automated insulin delivery, the first response will be a peaceful sleep. Because somebody who is diagnosed with a type 1 diabetes, the parent, the child, the adolescent, they could have never slept peacefully, uninterrupted at night. And that always used to be a dream. And that dream has now become a reality, to have a peaceful sleep with the help of this automation in the delivery of insulin. And in the first 25 patients, when we documented more than 83%, it was again a dream come true. Because in type 1 diabetes, we have never ever imagined that this will happen. Because it always used to be around 30 or only 35% time in range. But are we done with it? The answer is absolutely not. Not even 0.5% of people in India can afford these devices. But no, more than affordability, the tech need to be advanced further. There are limitations. There are clinic and physiological limitations. And if there is a pump failure, for example, which is not that uncommon, it can result in diabetic ketoacidosis. And if there is a sensor failure, again, not uncommon, it can result in a hyperglycemia. So you need to be cautious. You need to be overcautious when you are using these devices. And from the DTech team, and these are some of our own studies, we are also there with the public, with the patients, with their community. And this is a call for action. We need to have the India solutions, make in India solutions which are much more affordable, which can connect to any available reliable insulin pumps and continuous glucose sensors. And the API should be open. And this concern is there for the doctors, this concern is there for the patients, and this is shared by the community. And this is some update from the ADA. I don't have the time to go through all the updates from the American Diabetes Association. There are lot many devices which has been launched recently, and this is the one which is there available only in the US market, Tandem Mobi, and this is the twist system. You can imagine the size of this insulin pump, and this is sitting on my palm, and this is originally from a DIY community, the Tide Loop, and they're using the twist loop algorithm, and they claim that this can detect the insulin blockade, that is the pump blockage 9 times faster. I said in the beginning, the insulin infusion set blocks are fairly common with the use of insulin pumps, and this can detect it 9 times faster. But currently, the availability is only in the United States. So the question here is, because I was actually with the government panel along with Tade and Benshi when we were having the JPF meeting in July, and in many parts of the country, they are having identification, whom to be started on automated insulin delivery. And the answer is very simple. Everybody, so everyone diagnosed of type 1 diabetes, they deserve an automated insulin delivery device, because studies have shown that with the available solutions, you can reach 50 or 60 or 55% time in range, even with the older insulin pumps when they are not connected to the sensors. So even with continuous glucose monitoring sensors, when they are used along with a pump or a multiple daily injectable, the time in range is only around 50 or 55%. And the minimum which is required is more than 70%. And this can be accomplished only with the deployment of an automated insulin delivery. And this is why precisely the American Diabetes Association is identified, ISPAD, all the major organizations are now endorsing the use of automated insulin delivery in adults, in adolescents, and even in children soon after the diagnosis of a type 1 diabetes, and recognizing the disparities. Disparities are not there only in India, it is there globally. We cannot provide the same level of care as per the recommendations to everyone diagnosed of the same disease. And of course, even though there is a solution available, it need not be for everyone. The reason being, you have to identify based on the circumstances, preferences, and needs of the individual. Otherwise, this can fail. The devices can fail. And we are expanding the applicability. And many years ago, we have started publishing, and this was in 2007 and 2008, lot of publications on the use of continuous subcutaneous insulin delivery in type 2 diabetes. But after the launch of GLP-1 based therapies, and around 15 years ago, it used to be liraglutide, there has been a shift. So many people probably don't require an insulin pump with type 2 diabetes because we probably can handle them with the GLP-1 receptor agonist. But here again, there is a space. There is an entity called non-responders to GLP, and there is a major entity where they develop serious adverse events, GI side effects, and the drug need to be, the GLP need to be discontinued. So that can amount to 20 to 30% of the population with type 2 diabetes. So there are still indications for the use of CSII in type 2 diabetes. So now let me have a peek into the future, and this is a discussion on fully closed loop systems. And what are those systems in the pipeline? And just for another 5 to 6 minutes, is Amit around? Because Amit needs to leave. Yeah, I will finish very soon. So now we have rapid acting analog insulins, but these rapid acting analog insulins, they are not that rapid enough. And hence there is always a residual risk of hyperglycemia soon after the meal and then late onset hyperglycemia. So how can you tackle this? And the newer innovations are meant for no meal announcements, no manual bolusing. So this is a bolus priming strategy, and this is abbreviated as BPS, and the device will automatically deliver a tiny bolus the moment it recognizes a meal, and that too automatic. So it's all automated. So when you compare with the no bolus strategy with the bolus priming strategy, soon after the meal there is a pronounced reduction in the glucose, and then you can see that delayed also the same glucose response is sustained. And this is an ABC study on adaptive behavioral component. This is a randomized control trial exploring how the behavioral and the physiological adaptations can improve the outcomes in a tandem T-slim closed loop delivery system, and that is the control IQ. So here the control IQ is compared against the ABC, and here again there are two components. One is BAM, which stands for behavioral adaptation module, and then another one is ABC, which stands for adaptive behavioral component. So you can compare this with the self-driving automobile, and you are sitting, you are relaxing, and this is the behavioral adaptation module. And with behavioral adaptation module, the car is, you are trusting the car and it is learning the road. And with the other one, with the behavioral component, you are upgrading the car's brain so that it is sensing automatically the route, the favorite roads, the traffic, and so on. And that too completely automated. So look at the results. Not only the TR has improved compared to the original control IQ strategy, even the time in tighter range between 70 and 140, there is a significant improvement. So this is going to be the future, because with most of the automated insulin delivery devices currently available, to reach the dream target of more than 70%, with Medtronic it is relatively easier, but with many other devices, to reach the dream target of more than 70%, you still require a lot of manual intervention. So it is only around 65 to 66%. And that is why a lot of newer strategies are being tested. And this is with AI-enabled dual hormone. So we have been testing with dual hormone modalities for quite some time. And this is developed MBC algorithm. MBC stands for Model Predictive Control. And the dual hormones here will be one insulin and the other is pramlintide. And they're using a neural network MDD algorithm to detect unannounced meals. So the moment they are having a meal, it will detect that the person is going to have a meal, and then it will deliver both insulin and pramlintide accordingly. So this is the simplified version of the MDD, detecting the carb and then triggering the release of these hormones, and then dual hormone MPC core integrating insulin and pramlintide delivery, novel PKPD model based on meal challenge data. And then there are three strategies for the delivery of pramlintide. One is fixed ratio, and the other one is basal only, that is a constant pramlintide delivery, and the third one is independent, both independent, one pramlintide and the other insulin. So when you are comparing with insulin only model predictive control, this is the time in range. So when you compare insulin only strategy with dual hormone, whether it is fixed ratio or independent, it is more than 91% time in range. So it is very, very impressive. The data looks very impressive, and adjunct therapies are also being tested. Of course, it is there for a long time, and many of us are using most of these as off-label indications in type 1 diabetes when they are developing obesity or metabolic syndrome and other features, metformin, gliptins, gliflozins. And remember, adjunct 1 and adjunct 2 clinical trial with liraglutide, significant improvements in the body weight, more than 5 kilograms, and more than 20 to 25% reduction in the total daily dose of insulin, even in type 1 diabetes. And maybe from all those indications, you have even recommendations on how to change the settings in the insulin pump. So ICR, the active insulin time, you can increase to 3 to 4 hours if you are planning to probably involve a once weekly injectable. So these are the plans for the future. The three goals for the future for automated insulin delivery. Number one, no meal announcements and probably dual hormones. Adjunct therapies, maybe once weekly semaglutide or tirzepatide, and you can even incorporate them in the future ADA systems, and the future will be mostly patch insulin pumps replacing the tethered insulin pumps, and the continuous glucose sensors could be glucose along with continuous ketone monitoring. And some of these sensors are even having an option for heart rate sensing alongside the glucose sensing, and that makes sense. So with the consent of the organizers, this is again an opportunity for me, a very personal invitation to all of you. And this is an invitation to God's own country, to the biggest diabetes convention probably in the world now. We are number one in the world. And this is the 53rd annual convention of the RSSTA at Kochi in Kerala. So here I stop. Thank you very much, dear friends, for your patient hearing.